15% is where we are bladder and bowel toxicity. They were same in all the 3 arms, and grade 3 or higher, which is more severe toxicity, is about under 5%. So that is again a number you have to remember when you're talking to your patient, which brings us to what does this toxicity mean? Radiotherapy toxicities are there acute, which happen during the treatment, or late, that happen after 6 months, and they peak by about 18 to 24 months. And we use a large number of scales, but the most commonly used one is called the RTOG toxicity criteria. So what does it show? Grade 2 that I have been telling you about is moderate diarrhea, about 5 times a day, more than 5 times a day, intermittent bleeding per rectum, and some colic. That is grade 2 toxicity. Grade 3 is much more severe, defines as needing obstruction or bleeding, requiring some surgical intervention. That is grade 3. And urinary is moderate frequency. They don't say a number, but it's generally considered double of what was there on the baseline. And telangiectasia generalized on cystoscopy, and macroscopic intermittent hematuria. So if this happens, it is grade 2, and grade 3 is the severe one, which I said is less than 5%, is a bladder capacity reduced, severe frequency, severe telangiectasia, etc. So for the radiation oncologist, urologist, when you're talking to the patients, that 10 to 12, 15 is a number you should remember, and 5 is a number you should remember when you talk about the toxicity. So I'm going to end with that, and I'll be happy to take any questions. Thank you so much. We can't hear you, Dr. Jahangir.
Hi, yes, can you hear now?
Yes, yes.
There is. Yeah, Professor Shahidul Alam Khan, he said that is ERBT alone sufficient for radical treatment, or you need any adjuvant, all the cases you need ADT?
Sorry, is that a question for me?
Yes, yes.
Can you please repeat it?
Is EBRT alone sufficient for radical treatment?
So EBRT alone is sufficient for radical treatment, generally in low risk and favorable intermediate risk prostate cancer.
Right. I have another question, then we'll take a question from Professor Gupta. One is how long you want to give ADT prior to radiotherapy, and why?
For localized, for intermediate risk prostate cancer, generally, generally we would like to give ADT for about 4 to 6 months. That and an important thing is to cover the radiation with the ADT. So you would start it off and you would cover it during RT. It is important to continue the hormonal ablation. That is important. And the why is very simple. It's because multiple trials have shown that it improves overall survival. It is not just some biochemical or some soft endpoint. Use of ADT improves, short course ADT improves overall survival in these patients.
Right. Professor Gupta want to comment something?
Yeah, no, Vedant has already covered this point. But I would like to ask Vedant. Vedant, very good lecture. First, I want to compliment you for that. And now you have done a survey of your radiation oncologists. Have you asked this question to them? How long they are using hormonal treatment? Because in my and are they using in all cases? And also, I have, in my experience, I have not seen a single case where they have not given the hormonal therapy. Second thing is, in some cases, they advise combined hormonal therapy, means bicalutamide also. And to some patients, I have seen up to 8 or 10 years, they continued bicalutamide. I don't know why. And I have a lot of fight with my colleagues here in Delhi for that actually. So I'd like to hear from you, what is your experience and what do you comment? What should be done?
So if I understand your question right, did we ask whether they give hormonal therapy or not? Is that right? And did you also say
all cases, or select out the case only high risk or intermediate risk? Because in low risk also they give hormone therapy.
Yeah, I think low risk, I don't think there is any reasonable evidence or any justification to treat pure low risk with ADT. I don't think so. Favorable intermediate risk, sir, is more complicated. The Americans probably don't treat it, but most people in Europe, in UK, still treat favorable intermediate risk with ADT. So there is a little bit of divide there. We did not ask the ADT question because in our opinion or in our view, most radiation oncologists do give the ADT, and we were only asking about the contentious issue or issues that we thought would be, a little controversial.
Right.
You like to give bicalutamide also along with your
no
hormonal therapy,
no,
injection
no,
therapy, I mean to say?
No. So bicalutamide, I would recommend only in 1 or 2 situations. I would not recommend maximum androgen blockade along with the LHRH analog. That is not required along with radiotherapy. Sometimes in young patients who are very keen to maintain their potency, the LHRH really hits them hard and the potency completely goes. So that is the only time I would even consider for a short 6 months bicalutamide rather than an LHRH analog, 150 milligrams.
Not lifelong
No,
bicalutamide.
certainly not, certainly.
Can I get an attention, Professor Saloy, please? We find some of the patients from radiation toxicity, intractable hematuria. What is your experience on that issue? I mean, sometimes we cannot really control that. Patient keeps, it's sometimes respiratory. So what do you do in this situation?
Is that for me?
First of all, I would say in the last number of years with improvements in radiation therapy that Dr. Murthy mentioned, this is extremely rare in the US now, number one. I have a couple of very quick questions. You didn't say anything about the cyber knife, number one, which is increasingly popular, so you can treat in 5 days. Number two, don't you think all patients should be told about the potential risk with external beam with subsequent bladder cancer, which I've written a couple of papers about, which is not inconsequential. It's very rare, uncommon, but it does, for a younger patient, something to consider when comparing to surgery. And lastly, my own personal view, which I'm very pro radiation therapy for the proper patient, is that for a patient in which potency is very important, and let's say Gleason 3+4, and that you think needs treatment, interstitial to me seems like a potentially better choice than external beam. So 3 quick questions, if you don't mind. An excellent talk.
Thank you, Dr. Soloway. The first one was about using cyber knife. I did not say or talk about cyber knife because that's just a name of a vendor. So I assume you are talking about SBRT. I think Dev Narayan is going to cover that, so I left that out. We are a very high volume SBRT center. We are running a randomized trial in high risk prostate cancer as well, but I think Dev Narayan is going to talk about SBRT. Second one, can you remind me what I remember the third one, brachytherapy.
And the second one was about potential bladder cancer in the future as a risk.
Yes, that is true. That is true. If you look at the data from long-term data from randomized trial, there's about a 5% chance of not only bladder cancers but also some. But whether it is these papillary or non-muscle invasive bladder cancers happen due to the radiation, because radiation cancers are typically sarcomas, radiation-induced cancer. So that issue is always been a contentious issue. So, but there is clearly a finite risk. There is no doubt about it. But I think it's very difficult to pinpoint what the risk is and what exactly it is attributable. So we do talk about it. I think it is a discussion mainly that we talk about the GU and other toxicities.
And the other question was interstitial versus external beam for a 3+4 patient potency.
Yes. So we can debate about this for a long time, but interstitial brachytherapy in India and in Bangladesh have really not established themselves for a number of reasons. The main thing being we just do not have the caseload or the experience or the infrastructure to pull it off in a very common fashion, and there's training. So It's just not there, and we are trying to build different programs in different hospitals with high volume centers. Few people do it in few areas, but it's just not there.
Okay.
Having said that, the urinary toxicity that I showed you, particularly in the early part of your learning curve, is quite high with external beam, with interstitial brachytherapy. So that is why I think most people do not prefer it. And moving from EBRT to SBRT has been a much easier process for the radiation oncology community because the technology is same, the processes are the same. So I think CyberKnife like HDR like brachytherapy like dosimetry using CyberKnife platform is quite possible, and that is the way we are going ahead right now in this country at least. Till we have so many patients of early prostate cancer that we do a lot of brachytherapy as a country, I don't think it will take roots here very quickly.
Right. We are just beginning to start Dr. Devnan, Dr. with the last in the presentations. But before that, I just want to make a very quick comment from Professor Kamujjaman Chaudhary. He is a medical oncologist in Asina Cancer Hospital. So can you come with your comment? What is your experience in Bangladesh?
Oh, I'm presently I'm in Bangladesh Special Hospital. I live in Asana Cancer Hospitals. Yeah, really, Vedang has given a revived scenario about the total radiotherapy systems, what they're doing actually in prostate cancer, in localized prostate cancer in India. And so he has very good knowledge about the Bangladeshi situations. And he has been about the word, how the benefit of the 3D set and IMRT and which patient we can treat and what the toxicity in using the IMRTs and 3D CRTs. He has given a very nicely. And now the next speaker, I think Dev Narayan will just give you an idea about SBRT, what he's doing actually with the CyberKnife in his centers now with the institutes. We'll have the lectures from Dev Narayan, then we can discuss about that.
All right. May I request Dr. Devnan Datra is very well known to us. He is a radiation oncologist. He was working in America Institute of Medical Science. May I request him to start his lecture on SBRT in prostate cancer. Can you unmute your video, please? Dr. Devnarayan, we cannot hear you.
Now I'm audible?
Yes, now.
Yeah. So, good evening, Dr. Jahangir, Dr. Salam, for this opportunity. And it is an honor to be here. And talking after Dr. Vedang is very difficult because he has already covered everything about the prostate cancer radiation. Now, I understand that it is a forum where a lot of surgeons are there, neurosurgeons are there, and there are some notions about SBRT in prostate cancers. And I think we can discuss on few of the notions. Now, as SBRT is not the standard of care, surgery is considered to the standard. And if it is not possible, then SBRT is considered. That is, in many times the notion is, there's no randomized data comparing surgery and SBRT. So SBRT should be considered first, and if it is not possible, then SBRT should be considered in most of the patients, which is the notion. After SBRT, if there is recurrence, surgery is difficult, and that is why you should always consider surgery first, and RT should be kept as a salvage after the surgeries, because it's RT as a salvage is much better option. Now, in high-risk prostate cancers, SBRT is not possible. In low risk, there's no need for any kind of treatment. An observation is possible. And in intermediate risk, surgery is the standard of care. So that is kind of notions actually I got. And so I thought that we will clear one by one. And age is not an criteria for robotic surgery. So it is possible to do robotic surgery for elderly patients as well. Now, these are the notions, and we are going to talk about it. And what are the answers about SBRT we need to get? Is which one is better, IMRT or SBRT? What are the evidences of that the SBRT is useful in prostate cancer? And what is the long-term toxicity of SBRT? Means we always see that when you do a high dose of fraction radiation, it is the long-term toxicity that matters most. So we need to have a long-term data of SBRT to convince people that SBRT is one of the treatment modality in localized prostate cancer. And as Dr. Vedang told, there is not much comparison, but which is the most effective tool? And that is the most common question that we come across. Is VMAT, is Tomo, CyberKnife, which is the standard tool for SBRT? And is CyberKnife costlier than surgery or other radiation modalities? So these are the questions we are going to take, and I think these are the common questions that we all face in our routine practice. Now, about the notions, there is enough data that SBRT has a role in localized prostate cancer. There is more than 6,000 odd patients with 5-year follow-up prospective database, and I'm going to share that data. There is randomized data between IMRT and SBRT, and which has compared the toxicity and compared the biochemical control, and there is no difference in terms of biochemical control and toxicity. There is an issue, and that we are going to talk. So there is enough data on the role of SBRT in prostate cancer. There is no randomized data between surgery and radiosurgery in localized prostate cancer, and I agree with that. But there are some matched pair analysis which have shown that still 10 years after the radiation, there is no difference between the surgery and the radiosurgery. And after that, there is a dip because the number of patients treated with radiotherapy and more than 10 years follow-up is not there in that study. So it is difficult to tell which one is better than the other. And it is actually onus on the surgeons to have a randomized data on low-risk prostate cancer or intermediate favorable group prostate cancers to compare between surgery and radiosurgery, and then only we'll get the data. And I agree completely, there is no data, and which one is superior than the other is very difficult to tell. Now, about the anatomical recurrence risk after SBRT is 5 to 7% at 10 years, or whichever the data are there, it shows like that. And it is too low to be considered all patients with surgery. And there may be a cohort of patients which need surgery, and that is the standard of care. I agree completely. But there are patients where those patients are of higher risk of morbidities, and where radiosurgery can be a alternative options with 5 to 7% risk of recurrence at 10 years. And if you see the surgery, the risk of recurrence also not 2 to 5%, and what the literature says. So there might not be much difference between the recurrence rate between SBRT and surgery. And elderly, there will be morbidities, and SBRT may be a safer options in many situations. So elderly patients, SBRT can be a very safe option in many situations. Now, when we talk about SBRT and the data, this is the data we all talk about. It was published in 2013, 2 papers came, 2013 and 14, in one red journal, one in green journal of 1,100 odd patients. That time it was a huge data with Christopher King, which shown and 5 years follow that biochemical control is around 95% of the patients in low risk group and 84% in intermediate risk group. And the risk of toxicity, which came in other paper, which showed that it is less than 3% grade 3 toxicity. So, but that time, IMRT is the standard of care. SBRT was only this paper with a long follow-up, and more number of patients were there. So there was a requirement for a randomized study comparing SBRT and IMRT to see that the toxicity profiles are same or more with SBRT, and what is the biochemical control rate. Many people actually were concerned with the higher dose of fractions that rectal toxicities are going to be higher with SBRT. This study was published, which is compared, it's a phase 3 randomized study comparing IMRT and SBRT. And it is 1,200 odd patients with 600 odd in both the arms. And it has shown that there is no difference in terms of biochemical control at 5 years follow comparing between IMRT and SBRT. So IMRT and SBRT are similar in terms of biochemical control, and SBRT has an edge because it's a shorter duration of treatment. But if you see the toxicity parameters in this study, which shown that acute toxicities are higher in the SBRT arm. And it showed that the higher dose of fractions can have some issues, and that need to be handled, and we need to take into account it very seriously. Then a very interesting study came, the phase B study, which is similar kind of study comparing IMRT and SBRT. And it is a well-designed study, and where the dose fractionation schedule, the prescription isodose, all were predefined. 900 odd patients in both the arms, where it's shown that actually there's no difference in terms of toxicities, acute toxicities in both the arms. So this study actually proved that if it is done it appropriately, SBRT delivered appropriately, and the isodose prescriptions, the planning, those executions are done appropriately, then SBRT can be similar to IMRT in terms of toxicity. And we all know that the long-term data showed that that biochemical control is similar in both the arms. This is one of these two studies actually shown that if it is done appropriately, then SBRT can be an alternative to IMRT in localized prostate cancers. Now, then few more studies came. Actually, 2019 was the year where many of the randomized and prospective data on prostate cancer, in localized prostate cancer came out. This is 6,000 odd patients in 38 prospective cities and seen, and 5-year biochemical control is 95%, 7-year is 94% almost. And if you see the toxicity, grade 3 toxicity at 5 years, it is 2%. And most of it, they have done a prostate cancer specific scoring, index scoring system, which has shown that rectal and bladder toxicities, they return to normal after SBRT in 2 years' time to the baseline. So if you treat with SBRT, the complications of bladder and rectal toxicities are standardized and come to baseline abnormal in 2 years' time. So SBRT is a safe and effective option in rectal cancers, and it has been shown in 6,000 odd patients with long-term follow-up. So if you see this data, we can see very interesting that first 6 or 7 years, there is not much events that has happened. And after that, only few events has happened, which actually gave it 95% biochemical control. But first 5 to 7 years, there is not much events that has happened. And this, if you see this data, you show that if you increase the dose of radiation, then the biochemical control probability actually increases in this study. So it's shown that if you increase the dose, then maybe the biochemical control is going to increase in prostate cancers. Now, this is very interesting and very powerful study. It is 10 single institutional prospective study and 2 multi-institutional prospective study combined with 2,000 odd patients. And it is very well planned, well designed study. The prescription isodose is prescribed properly, dose prescriptions are properly, and toxicity criteria are done, and treatment was executed appropriately. And the outcome data of this study can define the role of SBRT in localized prostate cancer. Now, if you see the delivery, what Dr. Vedang was talking about, is very critical. In this study of 2,000 odd patients, 70% of the patients were treated with cyberknife. So it is a fiducial-based tracking with a minimal margin and appropriate treatment delivery with 7 years follow-up, and 50% of the patients were low-risk group. And very interesting thing is, only 5% of the patients got androgen therapy, and only for only one single dose of 3 months. So most of the patients didn't receive androgen therapy and treated only with radiotherapy. 47% of the patients were treated daily SBRT, and some of the group actually think that if you do alternative radiotherapy, then the complication rates are less. But in this study of 2,000 odd patients, half of the patients were treated single daily, half alternate day. There's no difference in terms of toxicity profile. So we don't need to unnecessarily increase the treatment time from 1 week to 2 weeks, and that is not going to decrease the toxicity. But delivering properly in properly matched treatment delivery system is going to have a better toxicity profile. Now, if you see the control rate at 7 years is 4.5% failure only in low risk. It is less than 5%. And in favorable group intermediate risk, it is 8.6%. Unfavorable 14, even 15%. So all intermediate risk, if it is taken together, it is 10%. So low risk group at 7 years, only 5% of the patients do fail biochemically. I'm not talking about the anatomical failure. And only 10% of the patients do fail biochemically intermediate risk. So it is a very, I mean, it is that more 95% of the patients have a control at 7 years, biochemical control. And we know that biochemical control does not always a anatomical failure. And actually it takes 2 to 3 years more to have an anatomical failure after that. So it is an excellent outcome data showing that SBRT is useful. Now, if you see about the toxicity of 2,000 odd patients, appropriately treated fiducial placed robotic radiosurgery system, grade 3 toxicity is 0.6% in GU and 0.01%, 0.09% in GI. So it is less than 1% toxicity if it is delivered appropriately. And if you see the late toxicity, grade 3 toxicities, it is less than 3%, 2.4% GU toxicity and 0.4% GI toxicity. So it is negligible amount of grade 3, grade 4 toxicities if we are delivered appropriately. I think someone was talking about CyberKnife and the role of CyberKnife in prostate cancer. This is where the prostate cancer CyberKnife actually has a huge impact, because as it is a fiducial-based real-time tracking system, so the delivery is appropriate. And if you are delivering appropriately, then the dose to the rectum, dose to the bladder is much more controlled. And that gives there is extremely low toxicity of bladder and rectum after treating with radiosurgery. Very interesting comparison of all studies of radiations with brachytherapies and external beam radiotherapy of different hyperfractionated schedules done in last 10 years. And the present study, which is treated with CyberKnife or robotic radiosurgery. And there are a few studies which is treated with LINAC-based SBRT systems or hyperfractionated radiotherapy system. If you see, the least GI and GU toxicity is with SBRT. It shows that it is not about the planning, it is about the delivery of the treatment plan is equally important to have an excellent toxicity profile and control rate. So that is where the robotic radiosurgery or fiducial-based radiosurgery plays a very important role in prostate cancer. Now, you tell that why that if you treat with prostate cancer with CyberKnife or robotic radiosurgery, fiducial-based, why we have a better toxicity profile than the LINAC-based radiotherapy in this cohort. If you see, we can actually mimic a brachytherapy. And as someone was asking that why brachytherapy is not picked up, because without putting a needle, we can have a brachytherapy-like dose distribution with radiosurgery. And if you can do it without putting a needle, why we need to do it? And we can mimic the similar kind of dose distribution parameters as a non-invasive procedure. Now, if you see the dose distribution parameters of CyberKnife and IMRT with the LINAC-based treatment, we should see that the rectal dose actually is less. And that is what is giving the lesser toxicity to the toxicity in the long-term follow-up data. So this 7-year follow-up data with 2,000 odd patients treated appropriately from a prospective setting, giving an excellent idea that fiducial-based tracking system and appropriate delivery in prostate is critical to have a less toxicity and have a good control. This is Dr. Vedant's paper. Now, in high risk, is there any role for SBRT? And when we are treating the prostate and the pelvis, it is a cohort of 68 that in future, maybe 5 years from now, the short course radiation, 5 days radiations is going to be standard of care, even in high risk prostate cancer. We have done a small exercise. You will not believe this dose distribution is actually with CyberKnife Holo planning system. We will able to deliver this dose. And actually after Dr. Vedant's paper, I did some exercise to find out whether we can have a similar kind of dose distribution pattern with CyberKnife, and what is the dose distribution to the rectum and the bladder, and how much time and how much monitor unit takes to do the treatment. You see, treatment time is 35 minutes for this, and if you do it a little better, it can become less than 30 minutes treatment time, and we can have a similar kind of dose distribution parameters, and it is practically feasible. We have not treated any patient yet, but it is practically feasible to treat the pelvic node along with the prostate with cybernape as well. Now about the dose escalation study, Dr. Vedang has already discussed about it, but there's some interesting study. Now, if you do SBRT, and metastatic in a metastatic way. So that may give an idea that how good the radiotherapy has worked. Very interesting that if you give less than 30 gray or 35 gray of radiation, it is 68% chance that there will be viable tissue if you do a biopsy. But if you give more than 37.5, it is 14%. And if you give more than 40 gray, it is 7% chance of having a viable tissue. And that gives us an idea that if you increase the dose, then there can be a better control and lesser chance of metastasis and local failures. But it does not come without a price. It comes if you increase the dose, then the increase the rectal and bladder toxicity comes into the picture. So we need to come into a balance that how much dose we are going to be able to deliver without having additional toxicity for rectal bladder. And it is actually 14.5, which thinks that it may be useful to limit our dose up to 40 gray in 5 fractions with SBRT. That is going to give us the best biochemical Now, this is another very interesting paper which I've seen in United States, and they have seen the last 10 years. What is the trend for radiosurgery? See, if you see in 2010 and 2015, it is almost doubled the number of patients who are treated with radiosurgery. But only 7% of all prostate cancers treated with radiation are treated with radiosurgery. So most of the patients are treated with hypofractionated radiation or conventional fractionation radiation. Only 7% of the patients still at today's date are treated with radiosurgery, where we have seen enough data to show that radiosurgery can be a standard of care in localized prostate cancer. Now, there are some very interesting things. Now, if you see in the academic centers, the more number of patients are treated with radiosurgery. If you see in urban people, they get more radiosurgery than the rural people in United States. So even in United States, there is a disparity between the people from different places and the treatment they receive. Whites get more radiosurgery than blacks. And patients who have a high income group, they get more radiosurgery than the poor socioeconomic status people. So there is a discrepancy between in the treatment of radiosurgery, and higher elite people and people who are from higher income group, they do get the radiosurgery more, even in US, and that is same in Indian population as well. And I think that many of the people from India is going to, and Bangladesh also will accept with that. We have done a very interesting study of our first 300 odd patients with treated radiosurgery, and now we have treated almost 600 odd patients. But if you see, only 2% of the patients are prostate cancers treated with radiosurgery. So it shows that though there is enough data, there is enough evidences, toxicity profiles and outcome data is at par with anything, but still the acceptance is not yet there, and we need to work on that. Now, another notion that I always feel that surgery is done by surgeons and radiation is delivered by the machine. That is completely not true, especially for radiosurgery and high precision radiation, where appropriate contouring, appropriate delivery is critical. Now, if you see, the apex of the prostate or the penile bulb gets the dose, then chance of having lateral dysfunction is much higher. 2% versus 14%. So to sparing the erectile, the penile bulb is critical to spare the erectile dysfunctions. So that is only possible with expertise, and someone is doing it regularly on routine basis. Similar thing for if your approval of a plan needs some expertise, because if you are not taking into account the host rectum is getting, the rectal toxicities are going to be higher. So you need some expertise and experience to deliver the high precision radiation therapy. So I conclude that there is enough prospective database with long-term follow-up data. We have 6,000 patient data. We have 2,000 patient data with prospective database with 7 years follow-up, which showing that biochemical relapse survival is around 95% at 7 years. And grade 2, grade 3 toxicities are less than 3% in all the series. There is no randomized data between surgery and radiosurgery, but we expect that results are almost the same. And robotic radiosurgery has a better toxicity profiles. Dose escalation may increase biochemical control and reduce the post RT positive, biopsy positive rate. And the role of radiosurgery in high risk prostate cancer is still evolving. So biochemical failure is more than 10%, 95% at 10 years, toxicity less than 2%, only 1 week treatment, it is outpatient procedure. Are we expecting anything better than that? So it is difficult to improve after reaching the peak. Thank you. This is my CyberKnife team in Amrita Hospital, and we have radiation oncologist, Dr. Jinil is on our team.
We cannot lost you, Dr. Narayan. So can we will come back again in the panel discussion.
So, can I just make a few comments, if I may?
Who is speaking?
I am Dr. Vedant.
Oh yes, please. We are looking for you.
So I think Devnarayan we lost as soon as he finished his talk. Maybe some technical issue. So I would just like to clarify. Hi, Devnarayan is back. Yeah. So maybe I'll just finish what I. So excellent talk, Devnarayan. You gave an excellent overview of SBRT. One of the things I think we have to be clear about is SBRT, and this is often a misconception. CyberKnife is not equal to SBRT. Devnarayan is a very avid CyberKnife user, and I really appreciate his experience and expertise in that. But in general, they are not equal. I don't know if there is CyberKnife in Bangladesh.
No,
or everybody.
We don't have. We don't have.
So that is the point. That does not mean that you cannot pull off moderate hypofractionation or extreme hypofractionation on a good linear accelerator with reasonably good imaging, onboard imaging. Without onboard imaging, it is dangerous to do it, either fiducial based or CBCT based. So those are the two things I think one should. And the other thing is the benefit of CyberKnife dosimetrically over LINAC based systems is there. Clearly it's there. You can modulate your treatment much better with a CyberKnife based treatment. But actually in practice, when you see the data wise, how will you reduce the high grade toxicity, like grade 3 toxicity, from 3% to you may bring it down to 2%. So it's really, you know, the kind of benefit starts to plateau. So don't despair if you don't have CyberKnife. If you want to start off in your practices, some patients you're already treating moderate hyperfractionation, I think it's fair. And I think Devnarayan will completely agree with what I'm saying.
Yes, I will. So now, let me give a clarification that though we talk about CyberKnife and we treat with CyberKnife, but CyberKnife is not everything. You can have an excellent treatment with IMRT, with proper imaging, proper patient preparation, say bowel, rectal preparations, bladder preparations. All these things are important. So people should not get carried away with their talk actually we have given. So it is all there. but at the same time, we can give an excellent treatment with our all LINAC-based radiation surgery as well.
So Jahangir bhai, may I make a one small comment, quick comment? It's Kamal. Hello.
Please, Kamal, please continue.
So thanks
Dr. Salam.
to both the oncology speaker along with the surgeon. I want to acknowledge one thing to everybody. Vedang make a huge contribution to our Bangladeshi oncologists for last so many years. And today what we are doing, that is we have moved from 3D to IMRT and doing some SPRT also. Thanks Vedang, personally and professionally, that you have really helped us remotely and also visiting us. Debrana, thanks to you also. You also came, but Vedang was very much involved with many teaching, and we were, highly supported by him, and still the support is going on. And last one question, small question to you, Vedang. As you said, sometimes we feel bad, we don't have a cyber. And similarly, sometimes some of our colleagues feel bad that we cannot give boost of HDR brachytherapy to high-risk prostate cancer. Are we missing something? Because we want to give the best, but unfortunately, till now we don't have. Many comment from you.
The first part is easy. Don't feel bad. I think you can pull off good quality radiotherapy. That is particularly why I showed 3D CRT. It is a good treatment for reasonable control. Second issue, I cannot do anything. Sorry.
Should I come in? See, I strongly believe there should be a cyber knife in Bangladesh, because if you compare India and the GDP of Bangladesh GDP is now much more better than India. So it should come in academic center.
Like Cancer Institute, yeah.
Cancer Institute. So it should come in academic center, and it can have a huge impact in terms of improving the quality of radiation in other centers as well.
I think government has planned for establishing 8 regional cancer centers. I think later on that will come actually. They can incorporate the cyber knife, especially as a research purpose and other things.
And after that comes Devnaran will say after 2 years,
yeah,
should come.
Yeah, we need things, but we need to get prepared to get these toys. That is also very important.
Yes.
Without preparation to getting this thing is more dangerous.
Yes.
Yeah.
Absolutely.
It needs a manpower. It needs a trained person.
Is there a panel or discussion right now, or we are?
Yeah.
No. This is Dr. S. Khan. I have one question to Vedang or Devnarayan. The ERBT or SBRT alone, there is a question, alone is sufficient. Only alone or with the brachytherapy is sufficient for the intermediate, high-risk intermediate group or high-risk prostate cancer?
So are you saying EBRT alone without brachytherapy?
Yeah.
He was actually the trial was shown EBRT or SBRT is alone.
So giving a brachytherapy boost, as I showed in my talk, giving a brachytherapy boost either with LDR or HDR in intermediate or even brachytherapy alone gives a higher dose to the prostate. So what happens, even if you can do the technique, even if you have the infrastructure, it improves biochemical failure-free survival as compared to EBRT. It does not improve overall survival. Also, giving a brachytherapy boost, because you are giving a much higher dose, increases the urinary toxicity substantially. So that takes many years for one to become an expert to reduce that amount of the urinary toxicity.
Yeah.
Okay.
Hello.
Jahangir.
And Dr. Jahangir is here.
Yeah.
You are muted, Dr. Jahangir.
Sorry. Thank you, Dr. Vedant and Dr. Debran Datto, Dr. Kamal and Dr. Kamrul Islam for your just immense knowledge on radiotherapy. We are very much naive on that, but even from now we know a lot of things about these things, so we can make some decision about the patients. immensely actually benefited the participants. I believe a lot of urologists there. So shall I go to the little bit of, if you bear with some 15 to 20 minutes, we can have some start with some panel discussion with our panelists. We are here a lot of persons from urology as well as. So may I request Professor Gupta sir, is he here or he's left? Professor Gupta sir.
I can try to compensate.
All right, okay. Probably it is too late.
A lot of discussion. It's already 9:30.
9:30.
So we enjoyed the entire presentation by each and every faculty, and it was a great meeting, I believe, and I personally learned so many things, and I'm sure that the participants were approximately 69 to 70 sometimes. Now it is, they have disappeared from this webinar. But still, Dr. Jahangir, you can continue discussion with the panelists for 2-3 questions, or if you wish, you can do more. But by next 15 minutes time, if we can finish it, this will be good justice to all the participants for dinner. So we do not like to stand in between the dinner and the and the webinar.
Right, sir. Can I start now?
Yes, please.
Right. About the prostatectomy, either open radical or robotic assisted rectotomy prostatectomy, what is the incidence of post-prostatectomy stricture, and how we can manage this? Because some patients comes with the post-prostatectomy experience. What is the actual right way to manage it? Can anybody volunteer us? I mean, particularly Professor Salam sir, you can come with the answer, or
I can address to this question.
Yes.
In my early part of my experiences, I faced quite a number of cases of prostatectomy stricture. They are not very easy to manage. They are difficult to control, and they require intermittent surgery in the form of dilatation or something like that. You cannot do big operation in this particular area. So all the way has to be done how to prevent it. One of the most important area that anastomosis should be perfect. And if you go for interrupted stitches, as we do in the open operation, is reasonably fair practice to eliminate the chance of strictures. But when continuous stitches are being applied with the open technique, there is a chance of constricting the anastomosis, and that may lead to a stricture that might happen. But interrupted stricture may be one of the prevention. In robotic technique as well as laparoscopic technique, they are more precisely being done, and continuous suture can be done with a precision so that stricture doesn't happen. So stricture happens approximately 2 to 4% cases. So it's not a big problem.
Right.
So if anyone would like to supplement.
Right. If nobody come with that, we have a next questions that, what is the incidence of incontinence after 1 year of prostate surgery? If the persistent incontinence, how can you manage that?
In 1 year time, approximately it should be less than 10%. It should be less than 10%. In my own practice, it is about 10 to 12% cases at 1 year practice, 1 year time.
It is 100% who suffers. So how can you manage it?
The best treatment is artificial sphincter, and I personally have tried with male sling, which is modified from the normal slings, but they do not work well, I tell you. So artificial urinary sphincter possibly is the best way.
You still have Professor Saloy with us? I cannot see him. I'm not sure.
Can you ask Dr. Saloy?
Has he left already?
Maybe.
Maybe. I think we have enough time today. We can have next day coming up.
Not enough time because people are going for the dinner.
Now we have enough time passed already. Simply.
Dr. Jahangir.
Yes.
Conclude.
Yes.
Soon.
I think we have some question. We can come in the next on the third day. I mean on third day of webinar we can cover all these questions at that time, because that is also
that may be a good idea.
Yeah, that will be a debate on it. So with thanking to everybody who is participated, as also as a panelist as well as participants, and everybody has actively participated here. And I think with all these things, we don't want to destroy your dinner. So please, I think I thank
so
everybody.
I'd like to.
So may I
Yes.
I think may I request Professor Salam sir to conclude the session.
Dr. Jahangir, you have done a wonderful job. You have performed the work of an author. No. You have presented very nicely. At the same time, you have moderated the session. Next week, we are planning for a debate between two persons. One is surgeon. He will talk about the role of surgery in locally advanced prostate cancer, and there will, on the opposite end, there will be role of radiation therapy in the management of the locally advanced prostate cancer. And with this debate, I will believe that we will try to recruit one of the best of the best speaker for you, so that they can fight. They can also disclose each and every points which are very important in managing the locally advanced prostate cancer. Locally advanced prostate cancer is a dreadful disease. It can kill the patient, but if it is treated effectively, then the patient can have, maybe with the intent of cure, every treatment is nowadays moderated, so they can expect a cure. So this debate will, maybe this will happen in 2 weeks' time after Eid. So we'll have enough time to recruit, and I believe that you will enjoy the debate, and we will make arrangement for that. And finally, we will conclude the masterclass on prostate cancer by ending up with the metastatic prostate cancer. That will be very interesting, as well as we can have some debate also on that metastatic prostate cancer, but we are not thinking right now. There will be one webinar with the metastatic prostate cancer. I believe that there will be very good discussion on that. That is a very hot topic. So I'm very much impressed with the participation. This is increasing day by day. I believe that more people will participate for their own interest, and we are also benefited. The question which cannot be addressed today, we hope that this will be addressed in the next meeting. So we are organizing this meeting for the benefit of the others. So please join us and strengthen us and participate us actively so that everybody become benefited. With this few word, I would like to thank you very much for active participation. Thank you. It would not be concluded until I pay enough thanks for our co-sponsors, particularly the Unimed UniHealth. They are offering unlimited, unrestricted grant fund and also help to conduct this, to continue this webinar and masterclass. So we'd like to thank them very, very much. With this word, I would like to conclude. Thank you. Thank you.